Good evening, everyone. Please welcome. Welcome, sir. So, good evening, everyone. Welcome to all respected faculties, those who have come from different parts of the country. So, hope you are liking your stay here. This is a kind of a resort, kind of a property we have taken for you so that we can make you feel home. And today, this is the first session of today's evening. For that, our moderator, sir, Dr. Ghansham Goyal, is already on stage. So, our first, sir, the stage is all yours.
Yeah, very good evening. Thanks to Dr. Supratik Bhattacharya and Team Lily for inviting me to moderate one of the important sessions. It's a pre-conference session. We are going to start it of the AMOCON, Metabolic and Obesity Conference. So we all know we have got more than 100 million obese people in our country and more than 100 million diabetic and type 2 diabetic, and every other type 2 diabetes is either overweight or obese. And then we have got more than 100 million pre-diabetics, that is there, and they are also obese. So obesity is one of the very important challenging scenario in our country, and obesity causes three important things. One is metabolic, mechanical and mental problems. So just like so in the metabolic problems, one is the obesity and type 2 diabetes, then MASH, previously we used to call it as NAFLD or NASH, then obesity and cardiovascular diseases, obesity and obstructive sleep apnea. Nowadays we are more and more aware about the obstructive sleep apnea, OSA, and stop bag, as we all are aware, is one of the preliminary or screening tool. By that you can identify that which patients are prone to have OSA. And then we will have all these four topics will be discussed. So first we are going to discuss about the obesity and type 2 diabetes, and for that I invite Dr. Rupam Das. Yeah, Dr. Rupam Das, please. Dr. Das is from Guwahati. He is a consultant endocrinologist. So can you display the CV, please? No. Okay. So now over to you, Dr. Das, please.
Yeah, thank you, Chairperson, sir, and thank you, Supratik, for the kind invite. And this is the, I think, second time I have come to AMOCON. Last year also it was a very great scientific extravaganza. I'll be talking on obesity and type 2 diabetes. We'll take up a case and then we'll go ahead. This is a contracted Eli Lilly session, but presentation I don't have any conflict of interest. So we'll take up a case, but case goes a little backward. Then it will come to the current time. So this Mr. Ravi is a male, 45-year-old male, an IT corporate sector person. His BMI is, this goes back 5 years. So we'll come to the current time a little later. So we'll take up his earlier thing, what the concerns were, and then we'll go ahead. So 5 years back, his BMI was 35.2 kg per meter square. Already he was obese class 2. Height 5'6" and 99 kg. HbA1c was 5.6, non-diabetic at that point of time. Blood pressure was okay, 30 by 80. Triglycerides little high, LDL is little high, HDL is low, and waist circumference is 42.5. So he's clearly a case of obesity 5 years back. Family history, his father has diabetes at the age of 50. That's his family background. And we then move ahead. So there is a poll question which says that what weight loss goal would we recommend for this kind of patients? Ideally, more than 15. But if he is not at all active, maybe 5 to 10% also will be a good to start with. But ideally, it should be more than 15%. So in this particular case, we need to look into what are the issues the patient is having, and then either he is open to his obesity, problems or not, and then we have to go ahead. We cannot just force some treatment to a patient. He has to accept that. So as an expert, we have to have a good communication with the patient regarding his weight issues. If the patient is open enough to discuss the issues on his own side, then it becomes a little more easier to come to a conclusion about what sort of treatment would help him. But if he's not open about his obesity status, then it becomes a little difficult situation. So what we need to do is we need to discuss about the myths and facts about obesity, and then talk about what are the priorities for the particular patient. Because weight is what is, seen in the face, but internally what sort of things might go wrong if it is not treated, that needs to be discussed with the patient for some treatment to be accepted by a patient. So definitely we have to recommend some treatment, and foremost weight loss will be a target, and we have to talk about the target and how to reach that target. It's not a, say, target of more than 15% in 3 months period. It's not possible. So we have to have a realistic goal for the particular patient, looking into his physical capabilities, and then move up with the targets. Lifestyle approach definitely has to be there, and it has to be a long life lifestyle approach. It cannot be a short course lifestyle approach. Pharmacotherapy and bariatric surgery consultation, since his BMI is quite high. So these are the options what we need to discuss with the patient, and then we need to come to a particular treatment for the patient. So now we come to the sort of current period. It's 2026, so 2026, I think just 3-4 months have passed, so it's 2025 has been put here, and he has now become a 50-year-old gentleman. And let's see how his weight and all has changed during these 5 years. Now he develops fatigue and general tiredness throughout the day. And hypertension is there. So that's his chief complaint, why he has come for the consultation. Now we see his BMI has increased from 35.2 to 42.7. He has, upgraded from class 2 obesity to class 3 obesity. Weight has not changed, and it won't change. Weight will be static, but his height will be static. He cannot increase in height, just that the weight has increased further. Earlier it was 90 something, now it is 120 kg. Blood pressure again has increased. And this point of time he has developed type 2 diabetes. HbA1c is 8.5, and waist circumference has increased from 42 to 50 inches. So now he's in a quite bad shape. So there are discussing points. I'll come to that later. But in these 5 years, he has changed a lot in his weight and his sugar status and everything. So you can see the fasting is quite high, 160 to 172. HbA1c is 8.5. Postprandial is also high. HDL is further increased of 160, triglyceride around 180. So you see that apart from weight, the other aspects have also deteriorated in these years. Hypertension has gone up, BMI has gone up, diabetes has come. So there are a lot of issues which has currently needs to be addressed. So for this particular patient, what treatment priority would we put now at the current time in 2025? Number one is either glycemic control followed by weight loss, followed by cardiometabolic risk modification like BP, lipids, and kidney, etc. Or number 2 would be weight loss followed by glycemic control, followed by metabolic risk. Or number 3, cardiometabolic risk modification, followed by weight loss and glycemic control, or weight loss as a primary target. What would the August, gathering think about it?
It will be weight loss followed by glycemic control followed by cardiometabolic risk modification.
In this sort of patient, we should all accept that when weight is a primary issue, it has to be handled first. If we look as a type 2 diabetic patient and think about the glycemic control alone, then it will not be sufficient. So that we have to keep in mind. So in treatment plan, again, we have to put forward a pharmacological treatment, and also a holistic care has to be given, not just the weight loss, but cardiometabolic health and glycemic control, everything has to come together. Another poll question, what would be the first line therapy for Mr. Ravi? Currently weight is 120. Number 1 option is metformin plus SGLT2 inhibitor along with ARB plus lifestyle. Second would be GLP-1 receptor agonist plus lifestyle. Third will be dual agonist plus lifestyle plus BP reduction plus lipid control. And fourth will be SGLT2 inhibitor, incretin-based therapy, either a GLP-1 or a dual agonist therapy.
Yeah.
Third, because weight loss, if we want robust weight loss with SGLT and metformin, it won't have robust weight loss. It would be a weight loss of around, maybe 4 to 5 kgs at the most, if associated with lifestyle. But highest weight loss and glycemic benefits we are going to get with a dual agonist. Along with the lifestyle, definitely we can expect greater weight loss, and other cardiometabolic risk reduction will be definitely there. So while addressing obesity, we need to improve or prevent significant detrimental effects. In a patient who has obesity, there will be multiple problems associated with obesity, and how much weight loss will give, what benefits, we have to look into it. So along with weight reduction, we can improve a lot of other parameters associated with obesity. So greater the weight loss, the reduction will be more associated with increasing benefits in majority of the diseases. Few other aspects of obesity management like MASLD and sleep apnea and cardiovascular benefits, the subsequent speakers will be addressing upon. But more the weight loss, more will be the benefit. That is what we have to get out of it. So this particular patient, we missed a golden opportunity 5 years back, and at that point of time, he did not have diabetes. He had weight issue and little bit of hypertension, and was dyslipidemic also, but without diabetes. Had we been aggressive enough to treat that obesity at that particular point of time, we would have prevented diabetes from coming. That is one thing. And other cardiometabolic events which occurred during this period definitely could have been averted. At the current time, he definitely has obesity along with diabetes, and definitely we need to be more aggressive about the pharmacotherapy and bringing down the weight to have a holistic benefit, and that way it will ultimately prevent the complications. At this stage also, he has not landed up in a event, cardiovascular event or other event. He has the, bad milieu for developing these complications if untreated. So early intervention definitely reaps benefit. That is what I wanted to present through these slides, that if we get any patient during the early periods with obesity, and currently what we can see is that acceptance of obesity has been quite good. previously, patients were also not very open about their weight status, and physicians also were not very open about the weight status, obesity management. But currently, with the good number of drugs which can address the obesity, very effectively, we are, coming up or opening up with the management related to obesity, and people are also gaining to accept the disease. And in fact, obesity has been now accepted as a disease like diabetes, because before a couple of years back it was not recognized as a disease. It was a lifestyle issue, but if patients are not open up about their weight issues, we cannot force them for a treatment. So now acceptance is becoming more, but we have to be very vigilant in our day-to-day practice to see which patients will require what sort of treatments, and then we have to go ahead. So we need to intervene early so that we do not miss the opportunity to avoid the occurrence of diabetes or other complications in the recent years. So I'll conclude by saying that this particular case, though it's a dummy case, but it gives us an idea that obesity's key role in type 2 diabetes management should be endorsed, and a treatment plan targeting weight loss, diet, exercise, and medications will improve blood glucose control and overall health. So a comprehensive care is what is needed, and we need to address early, or treatment has to be started as early as possible so that we can prevent the progression to type 2 diabetes. So thank you so much for the patient hearing, and over to moderator.
Thank you, Dr. Rupam Das. I think we will have a discussion or question answer session in the end. So please have your questions, because I think there will be a lot of discussion on these particular aspects which we have discussed. Give a big hand to Dr. Rupam Das for giving an excellent presentation. Now I invite Dr. Meenal Mehnoth. She is a consultant endocrinologist from the Manipal Hospital, Jaipur, and she is the, I come to know that she is the president of AMO, Metabolic and Obesity. So welcome at Kolkata. So Meenal, she is going to discuss obesity and MASH, Metabolic Associated Steatohepatitis. Now over to you.
Thank you, sir. Thank you so much. And thank you, Supratik, for this wonderful conference and having me here. Thank you, Eli Lilly, for this pre-conference symposium and giving me the platform to talk about something which is really, really important, and something which I really look up to, because it's a metabolic complication beyond the micro and macrovascular complications. So we've been studying the diabetes-associated micro and macrovascular complications, but the first time MASH, or rather MASLD, now what we call it, is something which is to do beyond the micro and macrovascular complications, and we start talking about the metabolic complications. So if I talk about this, these are my disclaimers. This is a Lilly-sponsored symposium. And these slides have been shared by Eli Lilly, and I've been contracted by Eli Lilly for this session, though the content will be thoroughly scientific. So we begin with how it happens. Like, what is fatty liver? See, what is adipose tissue? I will take few minutes because it's important to understand what are we talking. So what is adipose tissue? Adipose tissue, we understand, is either a subcutaneous fat or a visceral fat, right? It is cushioning most of the vital organs like our heart, kidney, even intestines, right? Then there is some specialized adipose tissue like the epicardial fat we have, or we have something in the bone marrow where it becomes fibrotic at times, right? So where does the fat come inside the liver? So liver is not a storehouse for adipose tissue or fat at all. So what is fatty liver? So the first key point to begin is this, insulin resistance. There is no pointer, I believe. So the first pathophysiological defect begins from insulin resistance. So there is insulin resistance at the level of adipose tissue. So there is increased free fatty acids, increased lipogenesis, more fat intake in our diet. So the body is flooded with free fatty acids. So these free fatty acids ultimately enter the liver. And when they enter the liver, they are stored as triglyceride droplets inside the hepatocytes, which is actually not designed to store fat. As a result, that ectopic fat becomes lipotoxic. So we end up into lipotoxicity. And here comes the role of interleukin 6, TNF-alpha, SOX3, JNK1, all pro-inflammatory markers which are released in the system. What happens? How does liver cope up with that? To cope up with that inflammatory markers and the extra adipose tissue, there is impaired mitochondrial beta oxidation. As a result, ultimately, initially the mitochondria inside the liver, they try to cope up, but then they get exhausted, they fail. So what happens? That leads to endoplasmic reticulum stress. And the ER stress, what does it do? It will give you unfolded protein. So the protein folding defect happens, and that leads to what? There is increased hormones under the influence of insulin, that is SREBP1C. As a result, mitochondria starts pouring out more of citrate back into the cytoplasm. There comes the role of ACCs and the FAS. So these are all hormones or the enzymes which are overworking. But ultimately nothing works, and finally the endoplasmic reticulum mitochondria inside the hepatocytes, they give way, and that leads to apoptosis. So the liver cells start dying. But we also have a defect at autophagy level, so the autophagus is not possible. So those dead cells, they are stored inside the liver. Liver looks for help from everybody, but nobody comes to its help. So it starts its own healing. So there becomes the role of the stellar cells, the hepatocyte stellar cells, which were actually designed to store what? Vitamin A. But no, now it is overburdened with fat. As a result, those hepatocyte stellar cells, they get converted into myofibrils. So there begins the phase of fibrosis. I'm talking all this because this is how mast cell actually develop. And with that mast cell, this hepatocyte fibrosis happens and liver progresses into cirrhosis. So that is the journey of mast cell. So the step one is insulin resistance. So that comes from obesity. So obesity is the genesis of mast cell. So insulin resistance followed by mitochondrial dysfunction. There are internal macrophages, the Kupffer cells. The Kupffer cells will release all the inflammatory markers, and from these autoimmunity, this immune pathogenesis, we will progress to hepatic fibrosis and apoptosis. So that is the pathophysiology of mast cell. Now, what is the role of abdominal circumference? Like the fat distribution is important. Again, I'm re-emphasizing, the subcutaneous fat is not your enemy. Your peri-organ fat is not your enemy. That is a cushion that is required. The problem comes with your intracellular fat. So that is very important. So the fat distribution is important. And that was the finding of this paper, which showed that most of the people with mast cell had a BMI of only 24. So what is important? The waist height ratio was taken, and the waist height ratio gave us this concept that it is the fat deposited around the abdomen which is dangerous. So fat distribution is equally important when we talk about mast cell. So this is the pathophysiology. So there is de novo lipogenesis, there is de novo gluconeogenesis. You have heard the concept, eat more fruits. You will have no sugars because there's fructose, but that fructose overloading will lead you to where? It will lead you to de novo gluconeogenesis, de novo lipogenesis. And there will be glucotoxicity, lipotoxicity, mitochondrial defects, endoplasmic reticulum stress, protein folding defects will come up. And that will lead to your MASH or mast cell, fatty liver grade 1 on sonography, then to grade 2. There is mast cell, there is cirrhosis, hepatitis, cirrhosis, and finally it can even lead to hepatocellular carcinoma. Thank you. So this is what we were talking, the journey, the normal liver. Excess fat in your diet, the adipose tissue fails to store it. So the increased free fatty acids, they enter the liver. There is also de novo lipogenesis, and this increased fat causes fatty liver. Then there is stage of steatohepatitis with these inflammatory markers. There is an adipokine triad. So this adipokine triad that is marked by dropped adiponectin and raised leptin and resistin. That leads to your adipokine triad, which is mainly responsible for MASLD. So here you look into the condition, then you will find that MASLD development is seen in almost 30 to 37% of obese population, but you can also find the lean thin MASH. Lean thin MASLD is also a known entity because we just studied that it is the fat distribution which is more important rather than the total amount of fat in the body. So now this is a paper from our very Indian authors who have given us some data that how the MASLD is hidden behind the bracket of all the metabolic complications. So you will find a population which is burdened with obesity, diabetes, dyslipidemia, hypertension, and if you look the same population in terms of the incidence of MASLD, moving to steatohepatitis, and finally to cirrhosis. And if we further follow them, maybe we will have data about the hepatocellular carcinoma also. So that is HCC. Now, obesity worsens the onset and progression. This is the longitudinal observation study. Again, it has shown that it is obesity which is the progenitor of MASLD, and it is not gender specific. I missed telling you that everything will happen on a genetic background. So there is a genetic predisposition. There are few specific genes which have been discovered. So it's not that everybody will behave same. Of course, there will be a difference how people in a population behave. That is why it is not 100%. That is why there is a variation. So everything what we are talking is in one subset of population who are genetically more predisposed and more vulnerable. So definitely we Asians are one of those populations. So you will find this data that there is increased MASLD for both men and women. So there is no gender bias here. We have to remember that we have lean MASLD also. So lean MASLD also is a known entity. And here again, the role remains the same, that the intrahepatocyte accumulation of triglycerides lead to steatohepatitis. Now coming back to one of the cases, now this is madam, she's 52 and she is class 2 obese, sedentary lifestyle. What do you find? She just comes to you with a complaint of a right hypochondriac fullness or a right hypochondriac dullness. Always complaining of bloating. She's always fatigued and tired. There is no history. The liver symptoms, the liver failure symptoms are not clinically evident. There is no jaundice, no pruritus, no hematemesis, no melena. So liver will not progress to complete hepatic failure state. What do you think? There is an underlying masked hypertension and dyslipidemia. So metabolic masking is there. You examine the patient and you find that she is overweight, obese with a BMI of 35.8. There is hepatomegaly. There is no splenomegaly. Why are we talking about splenomegaly? Can anybody tell me? We are talking of splenomegaly because of the platelet count. Because when we take FIB score, platelet counts are important. So FIB score, when we calculate the FIB score, we need to know if there is splenomegaly, there is bound to be thrombocytopenia and the FIB score is bound to rise. So there is no clinical signs of CLD here. Signs of portal hypertension again are absent clinically. So hepatomegaly with no ascites, ALT, AST raised. What are the normal cutoffs? ALT, AST, ALT above 40 is a danger mark. LDL is high, we need less than 70. Triglycerides less than 150 is a target, it's 210. Sonography is showing grade 2 steatohepatitis, steatosis. So now how sonography tells you the grade of fatty liver? It is just the observer variation, who the radiologist will compare the ecogenicity of liver with the kidney. If the two are same ecogenicity, there is no fatty liver. If the ecogenicity of liver is more than kidney, it is grade 1. If the ecogenicity of liver is markedly more, it is grade 3. If he can't see the diaphragm, he will say it is grade 3. Okay? Then we have to rule out the other causes of hepatic involvement, and most common can be the viral load, that is HBsAg, anti-CV, ANA, asthma. All these things you have to rule out to label it as MASLD or hepatosteatosis because of metabolic diseases, right? So now this is another study which is comparing the profile, the data, and you will find what we were talking, the markers, the AST, ALT markers here, you will find with no fatty liver, and the p-values are significant, markedly significant everywhere. Any p-value which is less than 0.05 is significant, right? So you will find that other than one ALP, every value is significant. And if you look at the positive predictivity and the negative predictivity, you will find that the ALT less than 25 has the maximum value. Similarly, GGT less than 15 has the maximum importance. It is the highest negative predictivity. So if your ALT is less than 25 and GGT is less than 15, you can rule out MASLD. So now the question, to label this patient as MASLD, do you need a biopsy? I can only see Dr. Sandeep Tak's neck from right and left. So biopsy is not routinely clinically done. So how do we label our patients as steatohepatitis? How do we do it? Is it just a radiologist vision, his reporting that we believe? No. So what do we do? There is a two-step approach. Number one, do a clinical FIB-4 scoring, for which you require age, AST, ALT, and the platelet counts. Okay, you have a calculators, you can do it. Then if the FIB score is more than 1.3 cutoff, if the patient is very old, you can take a cutoff of 2 also, or make it liberal. But for a young patient, take a FIB score of 1.3 as a cutoff. If that is positive, more than 1.3, you go for a fibroscan. So fibroscan is your step 2. So if your fibroscan is giving you LSM, that is your liver stiffness measure, and that is also collaborating with your FIB score, then you can label your patient as MASLD, right? Then comes your next question. Do you want an endoscopy? If you are friends with gastroenterologists, yes. So you can refer. No? Then don't do it. So finally, our diagnosis, so it's a case of MASLD with stage 2 fibrosis, and the underlying culprit is obesity or the metabolic syndrome. So what do you explain to this lady now? What should she do? Prescribe Mounjaro? No. So what do? We recommend her a weight loss of minimum 10%, right? Because most of the data supports at least a 10% of weight loss is required for reversal of fibrosis or the hepatosteatosis. So if you want to reverse the MASH, MASLD, whatever you call it, the nomenclature, but if you want to reverse it, then you need a 10% weight loss from the baseline. Anything is always acceptable, as Rupam just said. Even 3 to 5 to begin is good. Anything is acceptable, but please don't put on further weight. That is the first line, the golden rule. Aur mat badhana. Don't put on more. So anything is acceptable, but what we target a weight loss of more than 10%, and that 10% weight loss should be sustained. Important is it should be sustained. So by the end of 1 year, whatever weight loss.
2 minutes.
Sir, I'm just giving the last slide.
Yeah.
This is also a very overloaded slide, so I'm not going to read this slide anyways. I'm just telling you there are newer biomarkers, and one of the new biomarker is CK18M30. I'm not sure how much it is available in our labs, but the literature says there's a new biomarker of inflammation in MASLD which is raised, so you can follow it up. Or otherwise, we still follow AST, ALT, GGT, and that does the job for us. Then you have another paper, a lot of paper, and the crux is weight or obesity is the genitor of your MASLD, and similarly going back the same route, a U-turn, that is decrease weight, and you can reverse your obesity, your MASLD. And the target body weight loss is around 10%. That is the data, the literature. Thank you so much, and thank you, sir.
Thank you, Dr. Meenal, for excellent presentation, and especially fully explaining the pathophysiology of MSLD. So thank you. So I think everybody will be ready with all the questions, because in the end we will have a question answer session. Now I invite Dr. Sagarika Mukherjee. She is a consultant endocrinologist at the Charnock Hospital and a senior
Manipal
Hospitals, and Charnock also he was there.
Many years ago.
Yeah. So now she's going to discuss regarding the obesity and CVD, cardiovascular. Now, over to Sagarika, please.
Thank you very much, Supratik, for extending this invitation. I'm grateful to Eli Lilly for asking me to come and talk on their sponsored session. And thank you, Ghanashyamda, for the kind introduction. Most of the slides have been provided by Eli Lilly, and I have been contracted by Eli Lilly to provide this talk. So my talk is mainly focusing cardiovascular health problems and obesity. So I begin with a case vignette. Mr. Roshan, 38 years old, BMI 46. He's about 5 feet 8 inches high. He's got an irregular heartbeat, about 130 to 140 per minute. Blood pressure raised at 155/95. And he comes to the hospital with sudden onset of palpitation and feels fluttering inside his chest, and also complains of discomfort and a bit of short of breath. He's lightheaded, he's feeling a bit dizzy, but hasn't lost consciousness. And he's noted that over the last couple of months, he's been getting on and off these episodes of fluttering inside his chest. He's known to have diabetes and high blood pressure for over the last 2 years. So once he is in the hospital, he's got the baseline investigation, which shows atrial fibrillation with an irregular ventricular rate of 110 beats per minute. Echo shows left ventricular ejection fraction at around 52% with atrial enlargement. And 24-hour Holter monitoring also confirms that he's got atrial fibrillation. Lab parameter shows that his creatinine about 1.46, A1C 8%, lipid profile also grossly deranged. So here we are presented with this person with an AF, and we don't know really how are we going to assess his atrial fibrillation state, number one, and number two, what is his underlying heart condition like? Is he in heart failure or not? And how do we progress from here? So there are several questions. We need to establish about his AF. We need to do an electrophysiological study of his heart. We need to do that how much of his cardiac reserve he has and how much of exercise tolerance he has. And also we need to find out whether we need a coronary angiogram or not. So this person presents with paroxysmal atrial fibrillation. It's been happening on and off for the last 2 months, and he's morbidly obese with hypertension and a lot of other metabolic derangements plus type 2 diabetes. So there is a question whether he's got heart failure with preserved ejection fraction, and also there is a high question whether he's going to manage any exercise tolerance test or not. So when we define a score of heart failure, we look into several parameters. Number one, we look at the body mass. We look at the weight of the person or the waist-hip ratio and see what the body mass is like, and that gives you a couple of points. Number two, whether he's got hypertension or not, that gives you a second point. What is his heart rhythm? That gives the highest point, number three, atrial fibrillation or irregular heartbeats. Whether he's got pulmonary hypertension, what is his age like, and what is his filling pressure as seen on his echocardiogram. So the persistent atrial fibrillation over the last couple of months gives him a score of 3, a BMI gives him a score of 2, and all the other variables gives him just 1 score, as you can see on the chart, which is on the left-hand side of the screen. So given that he's got a score of 6, it's highly likely that he's got heart failure with a preserved ejection fraction. And now the question is, how much he can manage on exercise testing. Just a 6-minute walk test where he's expected to walk about 550 to 600 meters, which is the benchmark of healthy males of his age, and what is his performance as per this benchmark. And when we do a 6-minute test for him, it turns out that he cannot manage even just the 550 meters to 600 meters of walking, and which means that he's definitely got heart failure, but again his ejection fraction is preserved, so he's got heart failure with preserved ejection fraction, so his total functional capacity has been reduced. So here we have an obese person or person with obesity with number of metabolic disorder and plus a heart condition. About 2000 years ago, Hippocrates, who is the father of all doctors, had said that corpulence is a disorder, is not a disorder, but it's a disease, and it brings together the other organs of the body are also involved in corpulence or obesity or person with obesity and related symptoms. It brings along the other problems as well. We just now learnt about the liver, we just now learnt about other metabolic disorders, and now we are looking into a heart condition. We know that the obese people are very much prone into atherosclerosis related heart disorder, but this bit that obese patients are also very much prone to irregular or rhythm abnormalities which can lead to various other cardiac abnormalities. So this is something new. And why does this happen? So if you look at the cartoon on the left hand side, it says that excess amount of fat or adipocytes, it attracts a lot of inflammation, and alongside with adiposity, insulin resistance also tends to build up and your metabolic derangement sets in. You have obstructive sleep apnea syndrome, which sets up your sympathetic tone on a higher degree. You develop hypertension leading to vascular stiffness, and plus all the bad factors, all the interleukin 6, the IL-6, VEGF, and etc., all the inflammatory cascade that pours into your body, making your metabolic disorder even worse. And all of these things has got a deleterious effect mainly on your left atrium, leading to enlargement of the left atrium, leading to rhythm abnormalities. So increased atrial size really provides an opportunity for development of irregular heart rhythms or initiation of AF. And when you do imaging of the heart, left atrial enlargement is associated with atrial fibrillation, and onset of obesity, what it leads to, increase in your plasma volume, increase in your cardiac output or cardiac pressures, and that leads to increased pressure on your left atrium. And in addition to this, wall stiffness of the left ventricle leads to concentric remodeling and also creates difficulties in your afterload. So what is the main culprit? Why does obesity leads to atrial fibrillation? The main culprit here lies is your epicardial fat. Now epicardial fat, which lies very, very close proximity of the myocardium, is just not a fatty tissue, but rather it's an endocrine organ. It gives rise to a lot of inflammation, or it gives rise to it really acts like an organ, and close proximity of the myocardium, it really exerts its effect to the circulation through a paracrine signaling, and it's got an arrhythmogenic effects, and these are thought to be mediated by several mechanisms. Like in obesity, the epicardial fat accumulates, leads to a lot of reactive inflammation and synthesis of pro-inflammatory adipokines, which leads to the activation of the pro-fibrotic pathways. And although there is no distinct boundary between the epicardial fat and the myocardial surface area, so therefore they underline the atrial myocardium, and the pro-inflammatory and pro-fibrotic effects of the EAT really leads to rhythm abnormalities. So when you understand atrial fibrillation in context of morbid obesity, it can either be intermittent, that is an episode of less than 7 days, and often it is self-terminating. There is a persistent AF which persists for a long time, more than 7 days. There can be long-standing persistent AF with more than 12 months, or a permanent atrial fibrillation where you have to really make a decision that whether you are going to change the rhythm back to sinus rhythm, or whether you are going to have something else to do with the patient. So what happens with atrial fibrillation in obesity? It's mainly the apical fat deposition or epicardial fat deposition around the atria that leads to inflammation and fibrosis, and atrial enlargement is very common in obesity, mainly because of increase in blood volume, cardiac pressure, and raised susceptibility of atrial fibrillation. And as we know that obesity is a condition of chronic inflammation with rise to chronic inflammatory markers, and obese individuals are very much prone to have increased incidences of atrial fibrillation, and it adds on to your elevated risk of heart disease. As it is, obese patients are very much prone to atherosclerotic heart disease. So as it is, obese patients are very much prone to atherosclerotic heart disease. So when you have a rhythm abnormality, it really doubles or trebles your risk of morbidity, and it reduces your cardiac efficiency as well. So how are we going to approach this patient? We will have to have a holistic approach. We need to have a weight loss, we need to correct the heart rhythm, and most importantly, we need to give an emotional and the mental support to the patient. As it is, he's troubled by his weight. Every male really features that, if thinks that he will look like Hrithik Roshan, and every female thinks that she'll look like Katrina Kaif. But again, that's in the mind. And when you say you need to lose weight is doing this and that, that's a first mental blow. And another mental blow when you talk about the diet, that my biryani is going to go out. So these are really mental trauma that needs to be really nurtured properly. So how do we approach the patient? Definitely he needs lifestyle management. He needs a bit of a counseling, and on top of that, we need to control his abnormal heart rate. We need proper agents like beta blockers, calcium channel blockers in order to stabilize his heart rate. We need anticoagulants because atrial fibrillation is the largest cause of strokes. So we need anticoagulants, maybe vitamin K supplements, rhythm control with antiarrhythmic agents, or maybe plus minus cardiac ablation or cardioversion, and of course weight loss, lifestyle changes, bariatric surgery, GLP-1 agonist, GLP-GIP combination medication. Of course, these may come into the equation when we talk about weight loss. So here is a list of pharmacological agents that we can consider for rate stabilization. We can think of a beta blocker, anticoagulants like apixaban for stroke prevention, a statin. He needs telmisartan for protection of his heart as well as his kidney. He needs a metformin, and plus he needs either semaglutide or tirzepatide for obesity management, which has to be done in a properly dose escalated way so that he doesn't get the GI side effects associated with the medication and come out. He needs proper diet planning. The diet planning, you cannot say a man who is consuming say 2,500 to 3,000 calories per day, just you come down to 1,000 calories. It has to be done on a graduated manner, and slowly it has to come down. Otherwise, he's going to have plenty of cravings. So we need to go about some sort of like a Mediterranean diet, or something like a low carb, high fiber, moderate protein amount of diet. And remember, when you're doing a diet or any form of weight loss, along with the fat loss, there's going to be bound to have some muscle loss as well. Loss of muscle is really bad for everything. And so we need to rebuild the muscle at the same time. So how are you going to build the muscle? You need to have moderate amount of protein in the diet, and plus advise him to join a resistance exercise program or strength training program, from whereby he's going to burn his fat and preserve his muscles. And of course, we need some counseling and behavioral therapy for weight loss, not only for weight loss, but also to sustain all these regimes that are going to be prescribed to him. So obesity with atrial fibrillation is really because of the structural remodeling or electrical remodeling, which is induced by adiposity together with some neurohormonal changes, inflammation, fibrosis, and oxidative stress. Although it can be manageable with medication, but again remember, most of these cardioconversion drugs are lipophilic, and with excess amount of fat in the person with obesity, there can be some irregular or erratic distribution of the medication and may not have the desired effects that which we expect to do. Cardiac ablation or can be a bit of a problem in obese people. Weight loss definitely has got a beneficial effects in correction of the rhythm and maintaining a proper cardiac state in the long term. Remember that epicardial fat is obesity linked with atrial fibrillation in obesity, and thereby weight loss has to be done in order to reduce the epicardial fat significantly. A 10% weight loss is associated with significant reduction of epicardial fat. So we need sort of like a personalized treatment for early stratification in terms of lifestyle management, in terms of medication, and a sustained weight loss. So this person with obesity, hypertension, and metabolic syndrome, his rhythm was corrected, lifestyle was advised, medical therapy with rate control, anticoagulation, and metabolic support was given to him, and now he's much better. Thank you very much for your patient hearing.
Thank you, Sagarika, for excellent presentation. We'll have a question answer session in the end. So now I invite Dr. Dinesh Agarwal. He is the consultant diabetologist from the city of Guwahati. So he is going to discuss one of the very important aspects of obesity care is the obesity and obstructive sleep apnea. So please have your questions and all. So now over to Dr. Dinesh. Yeah.
Namaste. Good evening. Thanks, Dr. Sukrit, Lily, for taking out this wonderful case. obesity and obstetric sleep apnea is one topic which remains less discussed and we do not ask in our clinics. And this is a contractor talk. I have been contacted by the Eli Lilly for this session. So this is again a hypothetical case. Here Mr. Ramesh, who is 48 years old male, with age 48, with height of 172 and with weight of 102 kg, having a BMI of 37.9 kg. His blood pressure is 148.94 with a normal pulse rate, respiratory rate normal, and estimated pulmonary artery systolic pressure is around 81, which is higher, and he is not on irregular meal and not in the sedentary lifestyle. So now he presented to us with the excessive daytime sleepiness for the last 6 months. He also reported to have snoring by his spouse. He also have a morning headache, and he also complained of the poor concentration and memory loss and feeling not fresh even after 7 to 8 hours of sleep. He is a non-hypertensive for last 3 months on amlodipine 5 mg. He got frequent upper respiratory tract infection. There is a family history of obesity and type 2 diabetes mellitus, and he do consume moderate alcohol 3 to 4 times a week. Now on investigation by different scales which we do for the OSA, then he has 17 by 22 indicated of excessive daytime sleepiness. His apnea hypopnea index is 32 events per hour. We will discuss. This suggests severe obstetric sleep apnea. His SpO2 was found to be dropped to 82%. ECG shows mild right axis deviation, and his neck circumference is 46 centimeter, which is an increased risk factor for the OSA, which we'll discuss. ENT examination, which also shows the enlarged tonsil, crowded oropharynx, and Malapati score was class 3. Pulmonary function test, a bit of mild restrictive pattern. His TSH is normal with LDL is above target of 148, HDL is low, triglyceride is high. On chest examination, he revealed a right parasternal heave and loud P2 on auscultation, suggestive of the right ventricular pressure overload. So these are the focuses where he is not at the right place. So what is apnea hypopnea index? It is the number of apnea or hypopneas. Apneas are defined as more than 90% restriction of the airflow, and hypopneas in between 50 to 70% of the breakout, which is more than 10 seconds during the study per hour of sleep. It is generally expressed as the number of events per hour. Based on this index, the severity of OSA is classified. If it is less than 5 per hour, it is minimal. If it is in between 5 to 15 per hour, it is mild. And if it is in between 15 to 30, it is moderate, and in severe, it is more than 30. So in our subject, Mr. Ramesh, it was more than 30. Now question comes, which polysomnography variant we preferred? In lab sleep apnea test or home sleep apnea test or split night polysomnogram? Anyone who uses much. This is a one OSA which we do not ask most of the time in our subjects, and we neglect it. We do not ask. So let's discuss. Polysomnography, hospital remains the gold standard. Home sleep apnea test is easy. We can convince our subjects that you can take it at home and we can find out. And sleep night polysomnogram is a test in the initial phase. They do the test. If the OSA is found, they put the CPAP and then do the rest of the test to find out whether it is good or not. Now, in this case, we have found a neck circumference of 46. Do you agree that measuring neck circumference is obvious subject is helpful? Yes, it is the strongest independent indicator for OSA. Neck size more than 43 in male and more than 38 centimeter in female is a predictor or increased risk for OSA. There are various studies which are also finding it competent to see with the waist hip ratio also. Now, should we do a cardiac evaluation for this patient? Yes, we should do it. So there are various studies which we will discuss which says cardiac evaluation should be done to this patient. Now, most common form of sleep disturbance is obstetric sleep apnea, and it is an ongoing epidemic of obesity and leading to the increased prevalence of OSA. It is, as we have discussed, it is a frequently unrecognized and undiagnosed, and it do causes significant morbidity and mortality to our subjects. Now, what are the risk factors for OSA? male sex, older age, high neck circumference as we have seen, craniofacial anatomical abnormality, post-menopausal state, smoking, race, ethnicity, nighttime nasal congestions, overweight or obesity, enlarged upper waist soft tissue, and family history of sleep apnea. These are the risk factors. We always take history of all these things to our patient, but we forget to ask the sleep pattern and snoring from the spouse. Now, how does weight reduction sees improvement in OSA? This study, it is a small study in 9 weeks. The intervention group is from the low energy diet, which improved obstetric sleep apnea in men with an obesity in a small study of at least of 9 weeks also. In the intervention, this is the mild form has been seen favorable results. So at week 9, the intervention groups, the mean body weight was 19.8 kg lower than that of the control group. So this study shows that a small measures like a low calorie diet of 9 weeks also helps in the reduction of the weight, as well as it also causes helpful in the reduction in the obstetric sleep apnea. So my point was that by reducing weight, we can take care of this obstetric sleep apnea, which in turn lead to the many complications. Now, types of polysomnography, it's a gold standard. It takes 7 points like EEG, EOG, EMG, snoring. So we have different labels. Type 1 and 2, we have to take all the 7 parameters. Then we can have type 3 where we take the cardiorespiratory parameters, and the level 4 we can less parameters. So depending upon the availability, depending upon the individualization, we can do whatever we do, but the home sleep is a very good tool where the technician goes at their home, put the machine, and then next day we can get the reports. Now, if we talk about the pathophysiological cycle of this, we have a sleep onset, then reduced dilator muscle activity, there will be airway narrowing or collapse, then we do have a apnea or hypopnea. So as I have told, apnea is reduction of airflow by more than 90%, hypoapnea is in between 50 to 70% for more than 10 seconds. Then this lead to the hypercapnia and hypoxia, lead to the increased respiratory effort, aerosol, pharyngeal muscle activity, and airway opening. Again, there is a restorative breathing. So in OSA, we have a repeated start and stop of the sleep and breathing pattern. Now, what happened? How it related to the metabolic syndrome? We have a obstetric sleep apnea, intermittent hypoxia, leading to the more of oxidative stress, lead to the more of inflammation, which causes the neurohormonal changes. And these are bidirectional changes, neurohormonal changes and inflammation. And obstetric sleep apnea, there is a sleep fragmentation, deprivations, and all this lead to the inflammation, neurohormonal changes, sleep deprivation lead to the obesity, insulin resistance, hypertension, dyslipidemia. All this again lead to the type 2 diabetes mellitus, and it is a greater part of the metabolic syndrome. So what should be our treatment approach for this case? As we are talking, lifestyle and behavior modification remain the number one. These persons also require psychological support. Just saying that you are obese, you are having OSA, you need to do this, but we need to have a psychological support, and we do have a pharmacological management. So what it is, continuous positive pressure, airway pressure remains the gold standard. It was initiated to this subject. Amlodipine was continued for hypertension, atorvastatin for dyslipidemia. They have given a metformin due to pre-diabetes and insulin resistance. But we do have nowadays few trials like SURMOUNT OSA 1 and 2 with tirzepatide, which has shown the beneficial reports. This has been used with CPAP or without CPAP, showing the good results. So at least we need more than 10% of the weight loss for this subject to have a good result. So key outcome for this patient, clinical evaluation revealed risk factor for OSA, including increased neck circumference and the enlarged tonsil along with the newly diagnosed hypertension. Investigation polysomnography has confirmed severe OSA where AHA was more than 30 with the SpO2 going down to the 82%. His pre-diabetes with an HbA1c 6.1 having dyslipidemia and found to have a mild right ventricular hypertrophy. So management for this subject include the CPAP therapy, medication for the blood pressure and lipid. In looking at the pre-diabetes, metformin was considered and he was put on the comprehensive lifestyle modification including diet, exercise and sleep hygiene. The treatment goals including to this is to reduce apnea-hypoxia index to under 5, achieving a 10 to 15% the weight loss, normalizing metabolic parameters and improving quality of life. As I have showed that we now do have in our armamentarium tirzepatide, which has a it's a only molecule which has studies which surmount OSA type 1 and 2 with CPAP and without CPAP, where we have seen the good results. So that can be used to in addition of the lifestyle modification for the reduction of the bed. Thank you very much.
Thank you, Dr. Dinesh, for excellent presentation. Now I invite all the 4 speakers, Dr. Rupam, Dr. Meenal, Dr. Sagarika and Dr. Dinesh. Organizers, please put 3 chairs on the dais. 3 more chairs on the dais for the, yeah. At a 3 chair diye dao bhau. Eta rekhe dao aage. 3 chair upare dao. 3 more chairs. Yeah. So first I am going to ask one very practical question to each of all the speakers. So, yeah. Please come. Sagarika, please come. Yeah. Meenal, please. So, my first question to the first speaker, Dr. Rupam, he presented the case well, that he have shown his case initially weight means target, then lifestyle modifications, then third might be GLP or dual agonist, and fourth is bariatric surgery. So in your patient in 2020, probably you could have come out with the GLP-1 based therapy or dual agonist therapy. But in 2025, the BMI went up to 42. Like 42. So in that situation, you will advise these patients to have tirzepatide, or you will go, of course, on top of lifestyle modification, or you will go with the bariatric or metabolic surgery. This is a simple one. I think everybody will be interested to go for this question. Yeah.
I think still a dual agonist will be helpful in this patient. Though BMI is quite high, 42, where bariatric surgery is more, opted. But nevertheless, it's a surgery. So plus and minuses of surgery are there.
Because in the surmount 1 and 2, in 1, it has been shown the maximum reduction with the maximum doses of tirzepatide is 15 milligram once weekly, and the reduction of the weight was a tune of 22.6 or 22% of weight loss.
Yeah.
So are you going to reach at a target if you will start with that, or you'll go for direct with the metabolic surgery? That is my question. From the all who are here, who are interested how to go ahead with it. Yeah.
See, as a physician, I would suggest, drug therapy, maybe at the first go. But surgical benefits are there, but demerits are also there.
As I've mentioned, in 2020, probably the GLP-1 based therapy could have been helped. But
Yeah,
now
that time, I think that time it was not initiated.
Yeah.
Because of which it has.
You want to, Dr. Agarwal, you want to add something?
Bariatric surgery is easy what to be said, but it's difficult. You need to have more and more of psycho-counseling the patient. So GLP-1 and dual agonists are the medical bariatric surgery. If it has not been tried in the past, the person has to be given one chance to do that. So I will definitely do that, and at the same time, I will ask them, if not got the target, we can think of the bariatric surgery.
Meenal, you want to add something?
Sir, I agree with you. Because a patient with a 42 kilogram per meter square BMI will definitely not come to the target weight just by the pharmacotherapy. But again, because I agree with Rupam and Dinesh sir also, because if I recommend surgery, my patient will not go for bariatric tomorrow. So meanwhile he's thinking, meanwhile he's making up his mind, I should start the tirzepatide and give him the benefit of tirzepatide.
Yeah, your opinion?
Yeah, he needs definitely counseling. Just with diet alone won't do. So with a BMI of 42, even if you have 22% weight loss with GLP-1, still he's not going to have a healthy weight. So let him lose some weight, see how he goes. And if he's not able to lose the target weight, what you're want to achieve, say less than 90 or less than 80, then go for bariatric surgery. Maybe a, not such an extensive bariatric, just maybe a sleeve gastrectomy.
Actually, all four panelists now I will call, not the speakers. So I think it's the same as first, of course, lifestyle counseling. That is the priority, top. And then we can start with the dual agonist. And then even what we do in the bariatric center, as we are having a high volume bariatric center of the Eastern India. So what you will do, initially, if you reduce by 5 kilogram, 10 kilogram initially 2-3 months, and then patient convinced, and even the liver is soft, perform a bariatric surgery will be easier in that situation. So that is there. So first it can be tried, and if not reaching at the target, then you can go for the metabolic surgery. So now the second question, second speaker was Dr. Meenan. Yeah. So it was for the MASLD. So you see, you told yes, weight loss around 10% or 15% may reverse, 10% may reverse. We all know metabolic, mechanical, and the mental, or I can say image, body image changes. So that is there. So in your situation, you told 10% weight loss. We all know it's very difficult to go for it. Out of 100, hardly one is able to do that. So you have to start with some GLP-1 based therapy. Either it's a GLP-1 or dual agonist. With the ASCENS trial, which have got the benefit of around 63% benefit or reversal of the MASLD, and even there might be some in 32% or 33% there is a reversal in the early fibrosis also. You will go for semaglutide or you will opt for the tirzepatide, which is there. So dual agonist.
So
because the data are with the semaglutide. So
but the data of the Synergy NASH is also out, sir.
ASCENS trial.
Synergy NASH is also out. We have the data of Synergy NASH also now with us. So, and what I believe as a clinician, it is a molecule class effect.
Because everybody is interested to have this answer.
So
because these are the
we have the
questions.
data of Synergy NASH with us also. And as clinicians, we all understand the role is of weight loss, and that is a class effect. So it is a GLP-1 RA or a dual agonist. The ultimate target is weight loss, and the entire benefit is because of the reversal of the metabolic disorders and not GLP or GIP. It is a weight loss benefit.
So I think message is clear. Anybody want to add anything? Sagarika, you want to add anything? So thank you. So now third question to you. Yeah. So you have discussed one beautiful thing, that is a 6-minute walk test. So I think, I don't know in clinical practice, how many guys are performing 6-minute walk test in the clinic? But
not in the clinic, but in the cardiology clinic, you do have, just to have a baseline assessment.
As we are running the clinic since practically 20 years, 2006 we started with the obesity clinic and that, or bariatric surgery clinic. So we are performing the 6-minute walk test in each and every patient. So in this era of GLP-1 based therapy or dual agonist, or now the triple agonists are going to come. So because phase 3 trials has been already completed. So that is a miraculous drug. The weight loss is just equal to the bariatric surgeries. That is there. So in that situation, do you do in each and every patient of obesity 6-minute walk test? Is it needed or not? Is it indicated?
Not for each and every obese patient you need a 6-minute walk test. So which patient are you going to do a 6-minute walk test? In whom? Only in those whom you are suspecting there might be a reduction in his ejection fraction or whose cardiovascular status is compromised. You want to see the functional capacity of the patient, and accordingly you're going to intervene.
So it is a functional capacity which you want to see. If somebody is doing sarcopenia, in that situation you are going to do it in the patient. Suppose you started with the tirzepatide in the patient. And of course we all know, it is suppose 2/3, 1/3, or you can say 3/4 with the tirzepatide. They claim 3/4 is a fat mass, 1/4 is a muscle mass. And in the cases of semaglutide, they say 2/3 is the fat mass, 1/3 is a muscle mass. So to judge the functional capacity. What is the-
Functional capacity of the heart, not the muscle.
Muscle.
Just with a 6-minute walk test, you cannot gauge or cannot assess the muscle function of the patient.
Yeah. Your hand grip.
You need the hand grip test. You need
So-
the hand grip test.
So it is not needed.
No, it's only for cardiovascular functional status. How
Anybody
much
want
you
to
can
say
walk.
anything regarding this particular issue?
No, because this specifically what Madam's case was, it was a AF. And in this era of teamwork,
In the presence of AF, would you like to do a 6-minute walk
we
test?
will not.
Whether you have heart failure or not, that's what you want to assess.
Like-
His ejection fraction was 50.
His ejection
So
fraction
it
was
a preserved
preserved.
ejection fraction.
So
do that.
a case of HFpEF,
Yeah, Dr. Tak.
let's do a pro-BNP, anti-pro-BNP or whatever.
Of course, that is a marker for the heart failure.
So
We all
a
know.
case of HFpEF is a very difficult case. It is a HFrEF is easier to treat than a HFpEF. So
Also, you cannot assess clinically.
And
HFpEF is difficult to
HFpEF is clinically impossible. Patient will come to you healthy walking. It is only the pro-BNP which will tell you the patient is still in failure. And the echo is a big disguise. The moment you see EF of more than 50, you
operator
say, oh,
dependent.
आपका तो echo normal है, heart rate सब normal है. No, the patient is in HFpEF.
It is the operator dependent, which is very important. So now the last question to Dr. Agarwal, because about the OSA, this is
Yeah.
a very common entity,
Yes.
which people miss. We miss. I'll
Yes,
not say
definitely.
people miss OSA.
Yeah.
So I think in each and every patient who comes with obesity should be screened with the stop bang questionnaire. Stop bang, I think everybody knows. S, snoring. T means tired, means daytime sleepiness. O means observed. The wife observed the husband or husband observed the wife. One patient came to me 2 days back that, you see, I'm going at the verge of divorce. My wife says, you sleep in another room because whole night I'm not able to sleep on account of snoring. So that is, so observed, and then pressure. P means pressure, hypertension. And then bang. B, BMI. Then A means age. N means neck circumference, as Dr. Agarwal have mentioned. If it is less than 40, more than 43 in males, or less than 38 he have mentioned, but we standardly take 40 centimeters in the females, and G means gender for the male. So 8 points out of that, if it is more than 5, very high chance of having OSA. So I think each and every patient who is in obesity, they should have a stop bang
test.
Questionnaire should be done in each and every patient with obesity. So that will give the clue in which patient you have to go for a
polysomnography or home
one or
home one,
a
anyone,
split one or whatever the
anything,
hospital
yes.
one. So that is the one important point I just want to mention. So if anybody has any questions and comment on this very important symposium where we have discussed regarding all the 4 important aspects associated with the obesity. Yeah. Yeah, please. Can you have mic, please?
Mic इधर है. दादा इधर mic is there. Mic open.
No, it's very difficult whether you choose between tirzepatide and semaglutide in case of NASH, muscle MASH. You see the 2025 guidelines by ISO, they have given tirzepatide in the first preference, but once the ADA obesity guidelines came in January 2026, it has given semaglutide the top rank, A versus B. Because of the essence trial only, I believe. So essentially 29% reduction of resolution of this thing, liver steatosis, and the 63% prevention of going to the stage of steatosis. So basically it's very difficult. A lot of trials are coming out regarding the cardiovascular outcome also. So we have a time, we need to choose which one is the best.
But Maua, you want to say something?
So there are a lot many more in the pipeline. The ACC inhibitors are coming up, the FAS inhibitors are coming up, even the resmetirom is a big fight, the mitochondrial issue. So there's a lot many coming
You
up.
are going to be loaded within 5 years with multiple.
Same
There will be
thing
a
is
cafeteria
semaglutide
choice for
also.
us.
It's a lot.
Yes.
Yeah.
Very nice session. Congratulations, all of you. If a patient is having, obese patient is having osteoarthritis, what would you do?
Yeah. Anyone?
Weight loss.
I think here GLP
With what?
dual agonist,
Huh?
With which molecule? Dual agonist or GLP-1
dual
agonist?
agonist I think has
Uh,
a little
As over.
Maximum references come from the ortho department only because the TKR also works best after weight reduction. So, and the dual agonist has an edge. When it is non-diabetic obese, we will prefer a dual agonist.
But
Actually-
GLP-1 agonist has, they have data, right?
Data with the dual agonist is better for the weight loss, no?
No.
They have 22% weight loss.
Just a minute. Mahua is right because GLP-1 is a data. Even before weight reduction, it works on this cartilage of that. But of course, as we all know in Surmount 5, it was a head-to-head trial between SEMA and tirzepatide, and it has been shown there is 6% more weight reduction in comparison to SEMA with the tirzepatide. So for the weight reduction, of course, dual agonist is superior.
Better.
And weight reduction up to the tune of 15% is required for osteoarthritis to get the benefits. That is there, definitely.
Thank you. Thank you, sir.
Even the molecules have an effect at the osteoblastic and the osteoclast level also. So the GLP receptors are present on the osteoblasts.
Okay.
So that is why they work there also.
So, yeah, this is the last one. Yes.
Sir, at continuation with the heart failure discussion, we often come across patients with subclinical heart failure
Yes.
or with not overt congestion, but then they are not truly dry at the time of discharge from hospital.
Means NYHA class 2.
Yes.
2,
So
not 3.
what we also tend to ask these patients in our OPD setting is, before the NT-proBNPs rise, before we see basal crypts, is the amount of daily weight gain trends. That can be a subtle marker of congestion. Number two, a question to the all of four
If
of
the
you,
patient
sir.
is not having associated CKD,
Yes.
then it will be a marker.
Yes.
Otherwise, it's not. Yeah.
Number two is, sir, in CHADS-VAS score, weight is not a criteria for use of anticoagulation. But then again, obesity is a highly prothrombotic condition
Yes.
in association with atrial fibrillation. So can obesity be an independent criteria for the use of an anticoagulant? I mean, that is something that we can maybe discuss.
It's, I think, no,
universally no.
not.
Unless you have got very high risk factor. Say he's so obese that he can't mobilize. What about using peg stockings rather than an anticoagulant? Because those anticoagulants are all lipophilic. So distribution in the fat or erratic distribution might bring about more problems.
So, now give a big hand to all of my, I can say, panelists or speakers, and to me also. Thank you very much.
Thank you everyone.
We have, postgraduates who has traveled all the way from Rajasthan to attend this session. So thank you. Yeah, that's all for you.